Hello everyone, welcome to another session. Today we're going to talk about wound management. So I'm Uzma and I'm a GP in Dagenham, and today's topic, I don't want it to be like a lecture. And okay, before we start, I just wanted to just do some housekeeping rules. So if we're not speaking, can we go on mute, please? It just makes it easier to hear. Thank you. So I do want this to be interactive, and if you can put your questions in the chat, you can raise your hand. And Paul, if I don't notice it, if I'm too busy just talking and I don't notice it, please can you just mention that someone's waiting to speak? But I'm going to try and keep an eye on both things. I've got two screens on here, and so today's topic. This was something that was requested through surveys that the Training Hub had created, and they wanted it was about wound management. Now, this is a topic that affects a lot of decisions every day that we're making, and what you'll notice is that the way things happen in general practice is that wound management is not part of the GP contract anymore. So there's a separate contract. So anyone housebound is covered by district nurses, and anybody who can walk and is mobile, they'll be covered by a clinic somewhere. They will be like for example, in Dagenham, it's all at Barking Hospital, and there's a website that you go and you book your appointment. But it just means that this service is not available to you at surgery. But what happens is with care home residents is that some of the care homes are nursing homes, so you don't always get that support from district nursing. You'll get tissue viability, but you won't get that support from the district nurses, and you won't get that support from a practice nurse that the rest of the population, used to get. So it is a topic. It's a challenging topic, and it's just today I just wanted to cover just cover how do we do, what are the basics of wound management, and when does it sound like you need help outside. So I'm so sorry, but we have quite a lot of pictures in there, which might be quite upsetting. So I hope it's okay. So I'll just make a start. Does anybody have any questions before we start? But please feel free to write your question. Yes, go ahead. Yes, Avril.
Just a quick question. Are you going to touch base on how it becomes a pressure sore as well?
I wasn't planning to, because there is a bit in this at the end which covers types of wounds that you can. So there will be a little bit. We're not doing it in deep details, but if this is something that you would like to, I do know a very good tissue viability nurse who's very keen to do this topic. So just if everybody who wants to talk about this topic, what Avril's just asked, please put it in the chat, and we will arrange another topic around it. But it does, this webinar will cover a lot, touch a lot of basics in it. So see if this is enough, and otherwise just mention in the chat, and then we'll try and sort something out for everyone.
Great. Thank you.
Please feel free to put down topics that you would like to see. So what we're going to cover today are sort of skin wound basics. So the structure of the skin, wound types, the healing process. How would you assess a wound? So that will involve a holistic patient and local wound assessment tools that we use. What dressings would you use? What are exudates? When do you think it's getting infected? What's biofilm? And then we're going to look at some wound types like the diabetic foot, pressure ulcers, venous, arterial, and moisture related damage that we can see. So this is a picture of the skin, and it's just basically, you can see there's the epidermis, which is the top layer of the skin. Now this is the waterproof layer, and you know, once that's broken, that's when infection can start to get in. And then depends on how deep the wound is. Is it going through the full thickness of the skin? Can you see the fat layers underneath it? And that's how you will decide whether this is what grade it is. So we'll go through in today's session, we will go through these sessions, these different things. So in care homes, what I notice is it's not just like a clinical thing, wounds, because you know it affects their dignity, it affects pain, it affects their mobility, there's risk of hospital admissions, and often a lot of these wounds are preventable. So my question to everybody here is, because, you know, I like it to be interactive, if anybody is willing to answer, or just to have a discussion about what is the biggest impact that you see on your patients? Is it the pain? Is it the smell? Is it the mobility, or the dignity? Because imagine how many times you have to turn them over, and there'll be lots of people then assessing their, you know, back area, which can be quite embarrassing for a lot of patients. So which area do you think, which is the biggest impact you see of wounds on patients? Is it pain, smell, mobility? You can use the chat if you like. You can put your answers in there, or you can just speak. Don't mind. And as you know, the skin is not just a covering, it's actually a living organ. So once it breaks down, that's when the body shifts into damage control mode. And does anybody have any thoughts on like, why does the skin in elderly people fail so easily? Why does it, even with minor trauma? What is the main reason? Does anybody have any thoughts? Why does it break? You can speak if you like. That would be like helpful and nice. Yes, Avril, yes, the skin in the elderly is thinning. Yeah, so that's good. And I think it was about
in our home, like recently, a resident of ours who's got dementia, and she's elderly. She's also got diabetes. She's starting to start picking at her skin, and it's quite. And she's and I mean it's thin as it is. And what GP had told me was that as she's getting older, the skin thins. It's more susceptible to be thinning, and with the medication she's on, and with the diabetic medications as well, it doesn't help. And then she just happens to be fixated on spots or dots on her skin. So she's starting to pick little, you know, keeping her nails tight, short, but she's starting to get really attached to touching her spots and different marks on her skin. And we noticed a few weeks, well, about a month ago, she developed a wound out of that. And yeah, we had to call in the district nurses, but, you know, that's a most recent example of
what that happened. Yeah, yeah. I can see. I mean, it is like there is a condition where psychologically people get attached to skin picking, and it can happen in dementia and sort of patients when they're getting very anxious or getting depressed. So we do see that a lot. And often my patients want a diagnosis. They want me to tell them that this condition, I'll give you a cream, it'll get better. But you know, you can see how thick the skin is, you know, the epidermis, the dermis, depends how deep they've picked. The holes will take take a long time to actually heal from down outwards. And then scarring happens as well. So then that discoloration takes a long time. And if somebody keeps picking the scabs, you know, they never form. So as I said, the skin is quite a big organ in our body, and so the epidermis is the one that traps your moisture, and then you've got dermis, and you've got the dermis, which is the functional layer. It's got the nerve endings in it. So once somebody has picked deeper than the dermis, there's no pain underneath it. So often ulcers don't hurt because once it's deep enough, if you touch deep down, the white bits that are showing, and not the bones, I mean, you know, the fat. It doesn't really hurt at that point, but the bits that still has the nerve endings will hurt. And the subcutaneous is where you've got the fat cells, and that's where you get the insulation and the cushioning happening in the skin. So things that would affect somebody's, you know, factors that would affect skin barrier function. As we get older, the fat under the skin gets thinner and thinner. So that's why the skin starts to look thin and it starts to get wrinkles in it. So babies have that as well. They have fragile, thin skin. They don't have fat under the skin. So that's why if you have seen sort of on TV or something pictures of babies that are born early, and they're in the incubators in the hospital and they're premature or within the first few weeks of life, you know, their skin is quite thin and it is fragile, so it can very easily affect. So the other thing that affects is the moisture. So you will notice that patients who are lying on their backs for a long time or have got nappies on, the urine and stuff that's getting into it, the moisture starts to damage the skin gets moist and it starts to break up. Then also depends on the you know, on them on whether their skin is dry or oily. So dry skin seems to be thinner and breaks easy. So that's why having barrier cream and having sorry, I'm just gonna mute whoever it is. Thank you. Yeah, so that the dry skin, you know, so that's why having good, always moisturizing the skin is very, very good. So if it's looking visibly scaly, rough and flaky, just put some cream on it. There's a lot of creams that the GPs can still do for you. So with care home residents, even though we're not allowed to do these creams, I would actively do those prescriptions because I think that would really help reduce the pressure sores that people are getting, and it will just help improve the skin, because a lot of these patients are not eating well, so their nutrition isn't. You will provide them with the food, but a well-balanced diet, but they just won't eat enough quantities. So that's why when you don't have enough good quality protein going into the body, the skin and the muscle starts to break down and you get the collagen doesn't form, so you get the age-related skin changes, and then you get the skin breaking up easily. So what is a wound? It's not just a break in the skin, but it's a lot deeper than that. You know, when the skin just, you know, fails to protect the deeper functioning of it, that's when a wound forms. Because you can have a little cut, and I know in lay language we just call them a wound, because if you've had a little paper cut, you'd call it a wound, you know. But in medical terms, what is a wound? Is basically it's a skin that's injured and damaged and it loses its ability to actually repair or to protect the function and do the functions that skin needs to do. So yeah, there is something called repair versus regeneration, and that's why some people's body degenerates quicker because it's not repairing quick enough. So, so when this is not balanced, because whether they're hydration, whether they're, you know, they're not eating well, they're not hydrated properly, then this balance, it throws this balance out of the picture. So that's why it's very important for care home residents and people in general, just to make sure that they're drinking enough water, they're having good quality protein in enough quantities to protect and to keep their pressure sores, pressure areas intact. There's 4 stages of wound healing. So at first there is when it first opens up, you might notice that there's some bleeding and a scab forms. You get inflammation and then you get growth of the skin, so the proliferation stage. And then you get remodeling, which takes a bit more. So hemostasis happens in the first few days to a week. Then you notice that it's got a bit red and it's swollen. That's when it's like actively promoting skin growth and proliferation is happening. This takes about 3 weeks. And then after that, you'll notice that in younger people and children, this whole 4 stages of healing is very quick, and before you know it, it's all healed up. But in adults, generally, most wounds will take 3 to 4 weeks. But if somebody gets stuck in any of these phases, like Avril, your lady who's picking, every time there's a scab forming, she's picking it, and it's getting inflamed and it's proliferating, but it's not growing back because she keeps breaking the skin up. So the remodeling is not able to happen. So it's stuck in this phase. So you will notice that the healing is not going to happen. I mean, in your experience at your care homes, which stage do you think people get stuck? Is it like the scab stage, or do you think they get stuck in infections? Or do you think they actually get to the remodeling bit quite quickly in your care home? What do you feel? What do you think? I think a lot of people end up getting infections because remember, if somebody keeps touching it, and especially if it's in a sacral area where there's urine and infection, there's poo, it can actually make it chronic, and the infections can get worse. But I don't know what you feel, so please feel free to write in the chat or unmute yourself and just speak.
Yeah, for that particular resident, she went into antibiotics because it did get infected because she continuously just kept picking. So we did. So the GP prescribed some antibiotics, and then eventually, after district nurse team helped to bandage it in a way that she couldn't get to it so much, it helped. It took longer in the healing because obviously it's covered, but it now she's not picking it. It's complete. It's cleared up, it's healed, but it did get infected because of the consistent picking, and then there was antibiotics she had to take. Yeah,
that's good. Yes. So that's one of the commonest reasons that when they get infected, the wound gets stuck and it just doesn't. So normally it will heal within 3 weeks if it's a healthy individual, especially somebody who's well hydrated, the nutrition is good. And the remodeling can take up to a year. So the skin will look thin where the wound was when it's closed up and everything. And it will take about a year for the skin to start to look like the rest of the body. And then people can get stuck. Some things are very hard to heal. That's when you need specialist dressings, and you will need to get hold of tissue viability nurses. As far as I know, I think care homes can directly email the tissue viability nurses, and they'll be happy to advise you. So there is another concept, which is the moist wound healing, because you do need the wound to be moist for it to heal quickly. And this is one of the biggest mindset shift that has happened in wound care, because we used to think that the quicker it dries up, it heals quicker. But actually, you need a bit of moisture in it. Without that, the wound takes longer to heal. But if you've got too much moisture, and that's where we're going to talk about the exudates, if it's too much moisture, it won't heal as well. So, so the old thinking was that if it's dry wound, it will heal. But now new evidence is coming out that a moist wound heals faster. And the dry wound actually kills cells, so then they don't grow. But the moisture can hold it together and support them. Does anybody have any thoughts on why people still use dry dressings? Because you've got those gauzes and stuff you use to actually, did you notice that using the gauze actually helps them to grow faster or grow quicker, or do you use any silicone-based ones? That kind of, the squidgy foam dressings actually helps to hold in the moisture, lock in the moisture, keep the wound nice and supple. Does anybody have any experience? What do they use to cover? Any thoughts? Anybody heard of a word called maceration? So have you noticed that sometimes if there's like a wound, then that will actually, the edges of the skin, edges of the wound will start to swell up, like especially when you cover it.
Yes.
Yes. Is somebody want to come in? Is that Gloria?
Yes.
Yes, go ahead, Gloria.
Yeah. You said about knowing about maceration. Yes, maceration is more like when you soak your hands, actually, your normal fingers or part of your body. If you leave it in water for a very long time, it tends to begin to swell and all of that. And that happens to the wound area as well if it's not properly covered with dry because or something to keep it moist and to enable it to heal.
Yeah, yeah. And thank you, Gloria, for that, because Um, I'm just a GP and I do wound management, but not as much as our nursing colleagues do. So if you do feel you have something to add and it will improve information sharing amongst us here, please do share. I do like it to be an interactive and a two-way thing. So we're both learning as this webinar is progressing. So there's a lot of evidence that moist wounds actually heal 50% faster than the dry ones.
Yeah.
Yeah. So if you can prevent the wound from getting dehydration, that will help reduce the infection risk. There'll be less scarring, and it actually speeds up the healing. But if you have too much moisture, there will be risk of maceration, which then has other issues, which we'll talk later on in the. So there are some situations where moist wounds are not good. And I think the diabetic foot ones, I would suggest that that's the one where you don't really want moist one. This is a very specialist area. So I would say if you've got somebody like this, then that means if the toes are going black, the skin is going black on the toes, I would say you need tissue viability. Don't wait for the GP or anything. There's a lot that you can do without the GP intervening at that point. And just talk to the tissue viability nurse because they might need very specialist dressings. Which how many people here have heard of clicks? Clicks. Anybody heard of clicks? It's because as GPs we're not allowed to do prescriptions for dressings that you can get from Click. So every care home and these are not dressings that you pay for. You order them there, so you don't get a bill to the care home. There are some dressings that you cannot order for free. Those ones you can ask the GP to actually prescribe, and those are the expensive ones like the silver nitrate. And I think a lot of the silver nitrate ones you can get from the NHS website clicks. But if you need something expensive and it's not on clicks, then you can check with the GP. But before that happens, we will need kind of advice from the tissue viability to see that do they really need those, especially if it's somebody who's diabetic and is getting these fungating wounds, and they get this dry covering on it, which actually stabilizes the wound. So you don't want to debride it yourself. You do want some specialist help in there. Now, how does one do a holistic wound assessment? I mean, it does matter because, we want to get effective wound management. And without that, you will notice that you're stuck in that system where you're trying to heal a wound and it's just taking ages, it's not healing. If you're making inappropriate treatment choices, it won't heal and there will be poor patient outcomes. And then there's additional resources, cost to yourself, and then cost to the NHS as well and the patient themselves because they get depressed if they're stuck in a bed for ages because their leg ulcer won't heal. If it's a big one and it's leaking and they can't walk, they're in a lot of pain. It does affect them mentally as well. So always involve your patient in the care planning. And then it also does help because, like Avril's case, some people will actually take the dressings off. They just don't want to have it there. So there are three key areas of a wound, basically. So you've got the edges, you've got the wound bed in the middle, and then you've got the surrounding area. So having a look at that, so this one I think is slightly macerated. This one is AI has developed this one, so it's not a real wound, but it's AI related, and you can tell because I've never seen a wound that looks like this, like a star shape. And this, so you can see how the edges have become swollen, but you can see the wound bed in the middle, and you can see the liquid in it as well, and it's pooling, if you can see. And there's, I think there's biofilm there. So we'll discuss biofilm in a bit. So you want to do your baseline. You want to check that when did this, so I think this is where documentation is very important. So in your notes, if you can document when did you first notice it, because being in a care home and looking after a patient, there's a lot of responsibility, especially safeguarding and everything. So it's very important to know what the baseline is, what is the skin usually like, and does it break easily? When did the first sign of this ulcer or this wound happen? You look at the wound bed, you're looking at the edges, you're looking at the area around the skin, and just look for signs that you think this wound is extending. And that will actually help you create your management plan. So, I mean, obviously, some patients you won't be able to ask because they have dementia and they can't tell you, but you would know from the staff that are looking after the resident that when they were washing them this morning, so yesterday there was nothing, and then this morning when they checked, there was a wound that was there, and it was first noticed in the sacral area. And yeah, and then as it's healing, you just need to document in your notes that what signs are you seeing of progress? Can you see scab forming? Can you see that it's drying up, it's not bleeding as much, there's less exudates coming out? All these things you need to document, which means that there is sign of progress. It's nice if you can actually measure it and take pictures. So you do, how deep do you think it is? Are there any tunnels underneath it where you think there's liquid trapping? What is the tissue quality? Do you think it's healthy looking, or do you think it's looking that looking very pale and looking like it's going to get infected? What's the color of the liquid that's coming out? Is it serous? Is it see-through? Is it colorless? Does it have an odor in it? And what's the amount in it? And then obviously do check patients' pain levels with it, because some sacral pressure sores are very painful. Some diabetic ulcers are very painful, and it has psychological impact on them. So how often should one assess? Any thoughts? I mean, I've given you the answer there, so it's a bit obvious. So I would assess it every dress change, and it's at least a minimum once a week, because some dressings that tissue viability will give you, they will tell you it's only once a week we're going to change. So you set your dressing change according to your treatment goals. So if you've got a lot of exudate coming out, it's getting leaky, there's a lot of liquid coming out, you will do a lot more frequent. And remember, if you did it once or twice a day, you can't go wrong. And it might be that you're doing too much. It might mean it's costing you more in manpower and in dressings that you need to keep requesting. But remember, I think it's better safe than sorry. There's some wounds, the tissue viability will explain to you that it's a granulating wound. So if you change the dressings too frequently, it removes that wound bed that is healing. So those wounds you will need to do less frequently. So that's where I would say district nurses and tissue viability are very important. So if it's a large wound, and especially if it's not healing, I would say just start contacting your tissue viability nurse so that you know if you're using the correct dressing, and if you're changing it as frequent as you need to, or less, or if you need to do less. So there is a certain level that you can do. You can have this aid memoir kind of thing, like, so you could refer to the specialist if there's less than 20% improvement in a wound care. Now, how you want to assess the 20% is up to you, but you can say that, look, it's been 4 weeks and it's not healing. All I can see is that it scabs, but then it breaks up. whatever you want to say. If it's not healing in 4 weeks, then definitely you need to get tissue viability. If there's a sudden increase in exudates, you thought that it was healing, the scab was there, and then suddenly there's a lot of liquid starting to come out. If you suspect there's infection or you notice there's biofilm, sometimes the gray film on a wound is not always biofilm. It's actually very difficult to decide whether it is biofilm or not. But biofilm is just a layer of that bacteria that is, or whatever species, like whatever it is growing on it. And that will actually stop the healing process because it will block, it will keep the moisture trapped underneath it. So sometimes you have to remove the biofilm. And it actually increases pain. You know, if you get increased pain or you feel that the general health is declining, then that means you need to get more help. So yeah, documenting, I think a lot of you do it. The care homes I work in, they take a picture, they measure, they put a ruler next to it and they put down how many centimeters it is, record the size, depth, and make sure you put the date and time on it. And then you share it with your multidisciplinary team, such as your doctors and the other people at the surgery who will be involved in their care. Now, exudates and the wound gap. So this is something that is important for you to have a think about because it will delay the progression of the healing. So exudate is this thing, this film that develops. I'm sure you've all seen it because it's very common. Now, it is usually essential. It keeps the wound moist and it promotes cell growth, and it has the actual rich nutrients for the cells to grow and develop. So your body naturally produces an exudate in a wound when it's trying to heal it. And it helps to destroy the dead, damaged tissue. It's got stuff in it which actually eats up the dead tissue. But, you know, essentially sometimes it will go the wrong way. Now, I don't know if you can actually read and see this because some of you I know are on phones and the picture might be small. So you can see like this one, if you can see the mouse, this one's very yellow and to me that looks infected, but that was just a stock picture that, you know, I found. There's a serous fluid which will it will be thin and watery and is clear usually, but that's not much to worry about. Then there is this serosanguinous, and these are different terms that people use, like tissue viability, and it will get their attention if you use these terms. So this one is the skin that the skin would look red, and the exudate is thin and watery. Then you've got you can see the serosanguinous is thin. Sometimes it starts to get a bit thicker. And then that's like when it's getting infected, and then you can see it starts to get purulent. So you can see it starts to get thick, and the purulent one is thin, and then as it progresses it gets thicky and it gets fibrous. So when you pull it, it's like, like how there's cheese melted on pizza. It just when you lift it, it's like a long thin fiber. You can pull it. So it's very jelly-like. So when does an exudate stop healing? Because like we need exudate to actually help the wound to heal, but when is it going to actually be too much? So when there is too much or too little. So that's the thing, excess of it or not enough of it. And when the composition is wrong. So you're expecting a colorless, thin, watery stuff coming out. Sometimes it could look a bit yellow to you, but that's fine. That's okay. But if there's too much, the composition is wrong, or it's in the wrong place. So if it's pooling, because I'll tell you in a bit what does the pooling do to the wound. So you don't want liquid to just pool in one area. So the wound will get stuck in the inflammatory phase, because when you're getting exudate, that's when the inflammation is happening. Your body naturally does that. It makes the area red, causes inflammation. So it raises the temperature of the area swells up. It means it's actively healing. It doesn't necessarily mean there's an infection when something is looking red and swollen. And we see this a lot in cellulitis, the infected cellulitis. so the wound gap. So can you see there's a dressing on the skin and there's a gap there. So there's a gap over here. So this gap is where the liquid is going to pool, and it's like a dead space. So if you've chosen a dressing which is not giving you good contact with the wound bed, so you'll get this gap, and this is where the moisture will lock in, and it will actually stop this. It actually breaks the skin a bit more out of it, so it doesn't heal that well. And if it's an open wound, like diabetics get those ulcers on the foot, and the edges of the wound will start to swell up, and that's when the gap gets deeper and deeper, and in the gap you will get the exudate that is left there will start to grow fungus, or will start to grow bacteria, because our skins have natural bugs, and if you let them flourish, and especially when it's a closed space like that, there's no oxygen getting in, so these bugs, the anaerobes, the ones that don't need oxygen to grow, they will grow and accumulate, and it causes infections later on. So it's an infection risk. So managing this gap is critical. Now, I don't know which one you use, but there is biotin silicone, and it's a really nice cushiony. It's got a little bit of adherence in it, so it's a bit sticky and it's foamy. And what it does is it goes and it molds its way into these wounds. And obviously, some of them might not be deep enough, but with the foam, it can actually mold to the wound shape. So it's worth using these expensive ones. And I know these are expensive because I bought some for myself. I had something on my foot, and they were 10, you get 3 for £10, or sometimes you get 2 for £10, but they are supposed to stay on for 3 to 5 days at a time, so you don't remove them, change them that often. So you can see in the first picture, you can see pooling of the exudate is happening, and you can see it's quite deep and irregular inside, so there's lots of opportunities for gaps to happen, and this liquid that is pooling there to promote the wound healing is actually going to become a soup for growth. It's going to be warm and moist, and the bugs will just love it. And this serous fluid is full of nutrients, so it is this lovely soup, and these bugs are just going to love it, and they're going to grow. You can see in the maceration that will lift your dressings even more. So what happens is when the skin edges, like Gloria explained, when this water gets into that, so the exudate, instead of causing the moisture in the middle, is actually getting absorbed on the edges, especially when the gap is happening, you get this maceration type thing. And you can see like the area around the skin is not looking too healthy. It's sloughy and it's white, and it's just not normal pink colored. So that wound is going to take a long time to heal. And you can see there's like some tunneling in the middle. So there's like some white exudate happening there. So the exudate is pooling, the bacteria will love to grow. And yeah, so this is going to cause, because this person's not going to be able to wear a shoe and won't be able to walk around on it as well. So wound dressings, you need to choose the right dressing. Like we said, you want it to stay intact, you want it to stay and remain in place. You want to prevent leakage, you want to reduce the smell from developing as well. So a good quality dressing is actually quite helpful and very important to choose. Please don't feel worried about the cost of these dressings, because on Clicks you can go and order them and they don't cost the care home anything. And the ones that you need, which are not on there, please ask your GP to do a prescription. So most of us have a list of things that you can order on Clicks, so the GP will know which ones you can't order and which one you can.
Sorry, Uzma.
Yes.
There's a question in the chat about the previous slide about which dressing.
Yeah, that was the biotin silicone, and I've got the website address at the end of this, and I will share this with Paul so he can share the slides with everyone. And that basically you can you can do a whole course on wound management. It's like 10 hours long, but you can do it in bits and pieces. And a lot of these slides are from there as well, so it's quite useful. And I did use AI to actually do me this this website. So I put my slides up into Gamma, and then Gamma beautifies it like this. So it's something that's fine. So the content is mine, but I've just made it into these lovely little boxes with the user AI. So you can see these are the different types of dressings that you can use. You've got the basic silicone foam dressings. I usually tend to like the silicone foam dressings because they mold to the wound side. They ensure there's no gaps between the dressing and that, and they actually absorb a lot of the excess exudate. Then you've got the foam ones as well, and you've got some silver dressings, but silver ones, I think you don't always need them. That's usually, I would say, if you're thinking of silver dressings, unless you're comfortable and confident using them, I would say ask one of the tissue viability nurse that do we need them. Then you've got the hydrocolloid dressings, which don't actually have silicone in them or a base. They're just thick and they're meshy. Sorry, I went past that. They're meshy and they're see-through, so they're also very good. Certain dressings, certain wounds would respond really well to it, but not everyone. If you've got an ulcer and you've got, I wouldn't use a hydrocolloid ones. I would use hydrocolloid. Are good for like sort of eczema type skin rashes, but not if there's a cut or deep the uneven kind of cuts in them. Then you've got these contact layer dressings that people often use so that the dressing doesn't stick to the ulcer, because you know when you're removing the dressing, if the gauze sticks to the ulcer, it will remove the granulating wound bed, so you don't want that to happen. And then you've got gel fiber dressings, and these blue ones, which you pack the wound. So if it's a very deep one, you pack. But obviously, by that stage, you will have a tissue viability nurse. So don't worry. This webinar, I'm trying to just do what you can do on your own before you need tissue viability, and when will you need when will you actually need one. So now, if something is superficial, you can use the Biotane silicone. It's like those square patches that we see. And this is a brand name. The Biotane is the brand that you can actually buy it. Well, not buy it on clicks. You can get it, and it basically conforms. It molds to the wound bed, and it reduces the exudate pooling, like I said. Now, if something is a bit deeper, like 2 centimeter deeper, you can, some of these Biotane silicones, they will actually expand. You will actually see it will expand to fit deep into the wound. But if it's something very deep, more than 2 centimeters, you need the fiber packing to put in that. By that point, I would say if you think something is getting deeper, approaching 2 centimeters, I think you need to get tissue viability by that point. So now infections and biofilms. So this I would call is a film. Now all wounds have this film, and they have organisms, and these organisms actually you need because they're called our normal flora and they keep the skin healthy. But sometimes some of them will overgrow because of any gaps that forming moisture. Sometimes one particular organism will grow more, and you might have MRSA in the care home, because being in the healthcare environment, some patients go to hospital, they come back and they have MRSA, and you can't help it. It's part of nature, it just happens. So then they can grow into these wounds and cause infections. So what happens is that at first you will just see the biofilm and it will just be a contamination. Then you'll start to notice there'll be colonization, but that's still not infection stage. Then you'll start to see a little bit of redness at the edge of the wound, and that we call it just a local infection. For that, we usually give topical microbials, fusidin, sometimes people use, or you just clean the wound and you don't even need fusidin at that stage. Then you start to notice that the infection is spreading. So if anything is approaching 10 centimeters, that's usually something you need to get urgent help. but usually I think it's around under 10 centimeters, the GP can manage it in the community. You don't need to go to A&E. Systemic infection is when you start to get sepsis. So the infection is actually spreading around the body, and you'll get the signs, you'll get fever, you'll get the heart rate will be fast, and they'll be breathing fast, or the blood pressure will be very low. So that's the sepsis side of things. So you can see it can progress, and these are the different stages of wound infection. So when there's just local infection, there's just increased pain, there's swelling, there's red, you feel warm, there'll be more exudate than normal. This delays healing. And then the granulation is in some areas, you'll get the granulation. You will notice that the wound is healing irregularly. So it will say in the north, it will heal, but the south bit is not healing, and it could be basically, you just have to think about it. That is it the gap forming in that corner? Is that something that gets touched more frequently? What's happening? Yeah, and so you might get a smell. So I don't know if you smelled the socks, like the dirty socks, the smell. That is the smell of Pseudomonas, and it's usually a green color when it's causing infection. So our skin naturally has Pseudomonas, but when it causes infection, it will give you a greeny yellow serous fluid coming out, and it will smell like socks. And I'm sure you have smelt it on wounds when you are dressing them and cleaning them. So yeah, and then you start to get pocketing. So you get little areas where the skin causes a flap. So that's called pocketing. So that's a sign of infection. So when infection happening, there might be a little bubble that happens, and the skin separates from the dermis, and that's not a good sign. It means it's going to progress unless you get a nice silicone-based dressing, which will avoid gaps happening, and it will absorb the extra moisture and exudate and promote the wound bed to heal from down upwards. Obviously, systemic infection is when they get fever, there's an abscess, there's pus coming out, the wound is breaking down, you start to get tracking, you get cellulitis. Patient will just be a bit, generally have malaise, they'll be tired, lethargic. Obviously, you won't be doing the blood test. Now, lymphangitis is when you get tracking. So one from the wound, you will start to get a long, thin line along where the lymph, because in our body, you have the blood system, which is in the veins and the arteries. You've got the lymph as well. So that is something that is not very visible, but it's liquid. It's like clear liquid in our body, and it's lymph. And that has your immune system is in there. So if that gets infected, if you see tracking, then that means they need to go to A&E, because that means this is getting into the system. I would get them checked through urgent care. And remember, you need to look for those subtle signs. So lymphangitis is one I would say is a subtle sign. Patient will look quite well, but actually lymphangitis, you need to, get them checked quickly. If there's tracking, you'll actually see that there'll be tracking marks all over. So how would you treat the wound infection? Important thing is to cleanse. I don't know if you get saline pods. I would say those sterile saline pods. Now you can get them from the GP if you are unable to find them on clicks. I'm not too sure but where you get them from, but I definitely do them for my patients on prescriptions because I'm just not sure. Every time you do, just run the saline water on it, just get rid of all the exudate. Debride it, I do say aggressively, but debride the surface like as much as possible, I would say, like as if you have OCD, and clean as much as you can, but don't pull anything. So anything that you think will disrupt the whole wound, the wound bed, don't pull it off, but be aware that you want to remove as much as possible without any bleeding happening. And then I would say take pictures as much as possible so you can reassess and you can see whether it's working or not. And if you start noticing local infection signs, then I will escalate it to your GP so that you can get those topical fusidin or spreading. And then just keep an eye if you think they're spreading infection, it's lymphangitis, or you think they're getting fever, because you see fever is not very normal. I don't know how many times have you actually seen your residents get a fever. So in an elderly person, if they have fever, then that is quite a serious sign because they don't normally get fever. So biofilm, we just want to understand a little bit about it. Is that sloppy tissue? It's just when there's a lot of exudate, these bugs will love to grow in them. So that's called, it's not always visible to the naked eye. It does usually have a smell and it delays healing. So when do you suspect it? Now, I've never seen biofilm like this AI picture here, but it is like quite thick, stuck on type film. So just ask yourself, what do I need to do? Do I need to swab this? Is this wound failing to heal as I expected it? Is it just, taking a long time? So is it showing any signs of infection? Just escalate it to your GP. So if we have time, we've got 6 minutes left. I will show you, because Avril requested to talk about the pressure sites, and we can actually do one. So please do write to us or leave a message in the chat if you want to do tissue viability session. I can arrange that. It will be during the day, but that's something that we can arrange. So diabetic foot ulcers, it's only 48% of them will be alive in 5 years' time. So it has a very high mortality rate. So it's a very serious condition once it forms. So they do get very anxious and depressed. The 20% amputation risk as well. So yeah, so that is one of them. That's what it looks like. But it can happen in non-diabetics as well. So this will be, I would say, this needs very aggressive management, and you'll have support from the tissue viability and the diabetes community clinics will be reviewing, because this won't heal if the sugars are not in control and if their their health is not in control. So you will need a multidisciplinary team to get this healing, especially the vascular clinic, because this foot is at risk of amputation. So the important thing is to offload. So the more they can keep their feet up, because when it's hanging, there'll be edema in it, there'll be liquid forming, and there'll be blood pooling in it. So it's very important to offload. And blood supply should be adequate, because if you think that there is there's not enough blood supply in it, and this is something that your GP can check. They can check the artery, the pulse in the foot or in the hand, wherever this wherever you have the ulcer, if the blood flow isn't, then that's obviously a clinical emergency. I'll go to A&E. So you will need the help of a multidisciplinary team to look after a diabetic foot. So then you have different types. You've got ones that have deep cavities. There will be a specialist team looking helping you, so don't worry about it. You will get help at every stage, and if you don't, please ask for it. Please ask the tissue viability, ask the GP to get them into the diabetic clinic. There will be a low exudate, which is a dry wound, and there'll be a high exudate, and they both have their own challenges. But remember, the silicone foam is your best friend, and don't worry about the cost. When it comes to these wounds, cost is not an issue. So you've got different grades of diabetic foot ulcers. You've got grade 1, 2, 3, 4, just like pressure sores. Grade 4 has severe infection in it. The grade 1 is where the ulcer is there, but it's not infected. I start giving antibiotics, and some of them will be on 4 to 6 weeks of antibiotics, because the infection in it is very slow to get rid of, and it delays the healing. And the longer it's like that, the risk of amputation goes up. So we need to be very aggressive and proactive, and have a low threshold to get them admitted if you think that it's progressing, even if there's no gangrene. If you think it's getting bigger and worse, like that foot picture that I showed you, they need admission. So we've got pressure ulcers that happen where the skin is under a lot of pressure. It usually happens over a bony prominence. So that's where the skin it's still intact, but it will get red and painful. There might be some skin color changes. And then with pressure, the skin can just tear, and that's going to take ages to heal, especially because it's an area which is under a lot of pressure in a natural way. So people who are at risk are the ones that don't eat well, so they don't have enough protein and good quality. It's not a criticism on the care home, so always remember this. It's the patient's not eating enough. So Eggs are very good, good quality protein. So having eggs, 1 or 2 eggs a day, eating egg doesn't give you cholesterol. So it's actually quite a healthy food. And remember, it's only got 6 grams of protein in one egg. So if you give them a whole boiled egg, it's only got 6 grams. You need 1 to 2 grams of protein a day of your body weight. So if somebody's 50 kilos, they need 100 grams of good quality protein, which is like eggs, chicken breast, pulses, grains, there's chickpeas, there's all sorts of meats. So if they're vegetarian, you can still get a lot of protein in them. A lot of moisture, they need a lot of hydration. And remember, they can't eat that much. I realized I thought I had a whole chicken breast, which was 400 grams, and I thought that's enough protein, but actually 400 grams of of a chicken breast will only have 3/4 are 120. So it's only got 120 grams of protein, which is enough for somebody who's 60 kilos. But if somebody's 80 kilos, that chicken breast is not enough. It's only got, each 100 grams has got 30 grams of protein. So always check the box of the product. So chickpeas, a whole can of chickpeas, say it could be 500 grams, but it only has 50 grams of protein. So they'll have to eat a whole can of chickpeas to get 50 grams of protein. But usually, even if they can get 50 grams of protein a day, that would be enough. But I don't think they're going to eat that much. Plus, you need a variety of proteins because you've got all these amino acids that are needed, essential. They're called essential. So quinoa is a very good source of in a cup of quinoa, you've got all the nutrients you need for a whole one day, amino acids. It's amazing. It doesn't have all the protein you need for a day, but it has all the little amino acids that you need, the building blocks to create good skin and collagen and keep the skin intact. And then you need moisturization. So either you do it topically plus drinking water. So, like I said earlier, I wasn't going to cover pressure sores and ulcers because for an hour, it's not going to be able to do that. So please do mention in the chat if you would like to do, if you like another session on that. So this moisture-related skin tear. So you will often notice the nappy area would become like this. It gets a bit. So this is not a pressure sore. It looks very similar to it. But this is the more moisture-related skin damage that I think, Gloria, you were talking about when it gets a lot of water on the skin. So these slides are there for you to have a look if you want. And also, I've got the website address in the slide. So I'm not going to PDF this because then you can't click on the links in there. And it's run by Coloplast, and it has almost 10 hours of if you want to do it, it's free. So you just register with your email address and you can get it. And I'm pretty sure with any email address, I mean, I have an nhs.net email, so it did work with it. Didn't ask me any questions, didn't ask me my GMC number, didn't ask me anything. Yeah, I did ask me where I work, so just put down the surgery you're attached to be able to get access if you need to. Just ask the surgery, is it okay if I use your surgery as to access it? But I think it's free. You don't need to, because the companies actually make profit from when you use these different dressings, which is like amazing. So this is the biotin silicone that I was talking about, and you've got the fiber as well, which is used for packing. And there's this Alprep pad, which I don't know if you get it on Clicks, but you can use that to clean any, and if you want to clean and you want to get rid of the films in there. Yeah, so obviously when the urine, skin gets very irritated by urine, and you can get dermatitis, which is like eczema. So there's a lot more different types of wounds. So today I was just covering basic wound management, but there is other things like ulcers, different types of leg ulcers that need treating. And there is the venous leg ulcer pathway that I've put in the slides for you to have a look at. This one is a bit more specialist. You need to do this blood pressure of on the legs and the arm, and you get a ratio which your GP surgery can help you with. That is if you've identified they've got a venous leg ulcer. But usually your GP would be able to tell if there is this, and it usually needs referral to the vascular clinic. So yeah, so in a nutshell, you're going to cleanse, you're going to clean it, and you're going to make sure they've got a good moisture balance. You're going to protect the granulating, the epithelial, the gentle, the tissue that's growing in there. And you're going to keep an eye on the well-being of the patient to get a wound management. But this is what I mean by a holistic one, because you look at the whole patient, their pain, their well-being. So yeah, it's going to be a holistic assessment of the wound. Look at the wound bed, the edges, the area around the wound, manage the moisture, act early on the infection, and always involve the patient in decision making and what they would like. So, and remember, if you think it's not improving, especially by 4 weeks, you need to get tissue viability in it. And if you suddenly start to see a lot of exudate, there's a biofilm, or the patient's health is declining, then depending on whether it's sepsis, you will either call the GP or you'll get them admitted. So any questions? And these are the links that when you click on it, it will take you to the Coloplast professional websites, and there's this bunch of stuff over there that's really helpful. So thank you very much. Does anybody have any questions? I understand everybody into silence. So thank you, everyone. You've been lovely audience. But if you've got any questions, please email us. Happy to answer later on. And also do visit the Coloplast website. They've got lots of lovely material. And do let us know if you want the tissue viability session.
That would be very important. Thank you.
Thank you, Gloria.
Pressure source very regularly, so it would be nice to have an update on.
Okay. And is daytime a good time to arrange it during the day?
I believe it should.